Okay, I'd like to call the hearing of the Military Personnel Subcommittee to order. I want to welcome everyone to the hearing. I thank the witnesses for their flexibility. Just to say at the outset, we're probably going to have another vote series at 12:30, which will be a one-vote series. So my plan is that when the bell rings, whoever's speaking will finish what they're saying. We will depart, go vote that one vote, and come immediately back if we have not yet concluded the hearing. So again, I want to thank everyone for coming to the subcommittee hearing to get the stakeholder views on proposed military health care reforms. This hearing is part of the committee's ongoing project to comprehensively review the current state of the military health system and military health care, and based on this information, identify areas that need improvement. Now, I want to be clear that this process is not being driven by budgetary concerns. We're using the same format that we used in the successful review of the military retirement changes, which were not driven by budget, but driven by what will produce the best possible benefit to be able to recruit and retain the best and brightest into our all-volunteer force. The overarching goal of the project is to ensure the military health system can sustain trained and ready health care providers to support the readiness of the force while providing a quality health care benefit that is valued by beneficiaries. To that end, the committee has heard from several experts, including current and former Surgeons General, the Undersecretary of Defense for Health Affairs, and civilian health care programs regarding the current and future challenges of providing health care. Today, we look forward to building on the knowledge by hearing from military service organizations regarding their members' views on military health care. These incredibly important perspectives are crucial to understanding this multifaceted and complex issue. Our purpose today is to discuss both what works and what needs to be fixed in the military healthcare system. We are keenly aware that military healthcare is an extremely important benefit, and any reforms must be thoroughly analyzed from multiple perspectives and structured to prevent unintended consequences. Our discussion today is an integral part of that process. Before I introduce our panel, let me offer the Ranking Member, Congresswoman Davis, an opportunity to make her opening remarks.
Thank you, Mr. Chairman, and I also want to welcome, of course, all of you to this hearing. Your perspective and your views have always been very important to us, and particularly as we have been engaged in the healthcare reform discussion. And Admiral Ryan, I understand you'll be stepping down. Is that correct? Yes. As President and CEO of MOA, and we just want to thank you so much for your service. I know that everyone in the organization feels the same, and we appreciate very much the work that you've done. We've had the opportunity to hear from some of you this past spring as we began working through many of the recommendations of the Commission. And you know that we did address retirement reform as well as several other Commission recommendations in the NDAA. And we've made progress in healthcare reform by instituting a pilot program on urgent care, requiring the DoD to publicly post access standards and requiring DoD to improve TRICARE enrollment during duty station changes. And I think we can all agree that there are areas of the healthcare system that work very, very well. And yet there are some areas that we can improve. And so that's the challenge before us, I think, to try and make these improvements while maintaining a superior standard of care. I know each of your organizations represent particular constituencies and particular concerns, so we're eager to have your insight and your thoughts. Thank you so much again for being here. And I might say, Mr. Chairman, that I believe with the votes kind of got us off schedule that I may need to leave in the middle, but I'm hoping that we'll be able to hear from all of you before that and even some of the questions. Thank you so much.
Thank you, Ms. Davis. We are joined again today by an outstanding panel. We will give each witness the opportunity to present his or her testimony and each member an opportunity to question the witnesses. Respectfully remind the witnesses to summarize to the greatest extent possible the high points of your written testimony in 5 minutes or less. Your written comments and statements will be made part of the hearing record. Let me welcome our panel, Mr. Scott Bosom, Legislative Director of the Enlisted Association of the National Guard of the United States, Vice Admiral Retired Norbert Ryan, President and CEO of the Military Officers Association of America, and Ms. Joyce Razor, Executive Director, National Military Family Association. I also ask unanimous consent to enter a statement from the National Association of Chain Drug Stores into the record. Without objection, so ordered. Who's going to go first? Mr. Boson? Okay, you're recognized for 5 minutes.
Chairman Hick, Ranking Member Davis, esteemed subcommittee members, my opening statement is part of my written testimony, and since we have a kind of a tight schedule with votes, I'm willing to just submit it for the record and not read.
Or can you give us a quick summary in 5 minutes of what your statement says so we can move forward? So everybody has an opportunity that may not have read your statement in advance. what the views
Absolutely.
are.
Yep, no problem. On behalf of the Enlisted Association of the National Guard, it is a pleasure to testify on the critical issue of healthcare reform. Our membership represents over 414,000 enlisted men and women of the Army and Air National Guard, their families and survivors, and the tens of thousands of National Guard retirees. Each and every year, one of them is affected by healthcare when the Guard mobilizes in support of our country or when they fulfill their strategic missions. We welcome this opportunity to submit testimony for the record. Our members appreciate the countless hours that you and your staff have devoted to ensure that our service members receive the best care. Under committee leadership, the National Defense Authorization Act committed the Military Compensation and Retirement Modernization Commission. The commissioners made recommendations to ensure to Congress on how to improve health care access that would eliminate problems currently encountered by Guard and Reserve members and families. We encourage the committee to consider the Commission's final recommendations as they explore health care reform. From the Guard's perspective, it's difficult to discuss health care without addressing the complexity of our duty statuses. The military's complex personnel system directly affects Guard pay, health care, and even burial rights based on what duty status orders are published under. The focus of today's discussion does not include National Guard duty status reform, but I suggest that the type of health care coverage members receive should be separated from whether or not they are on active or inactive duty military orders. Service members and their families should have one health care program regardless of duty status. Separating the two would fix the continuity of care issue, creating problems for members of the Guard and their families. As you consider changes next year, please keep in mind that access is a problem because most members of the National Guard do not live on or near military installations. As a result, many of our members drive hundreds of miles for appointments only to be referred to a specialist who may or may not be available under TRICARE. Additionally, their frustration is compounded because appointments may not be scheduled in what you or I would consider a reasonable time frame. This association, in conjunction with the Reserve Officers Association and the National Guard Association of the United States, circulated a healthcare satisfaction survey to our members. The results of the survey are enclosed with my written testimony. After reviewing the survey results, I'm not prepared to say that TRICARE is broken. I want to recognize the Reserve Officers Association and the National Guard Association of the United States for their input in today's testimony. Together, our membership make up the entirety of the reserve component, officers and enlisted, and all over 1.1 million members, which includes every mobilization category. So thank you again for hosting this hearing. As the discussion continues, we look forward to working closely with you and your staff as you look at military healthcare reform.
Chairman Heck, Madam Ranking Member Davis, Congressman Kaufman, Congressman MacArthur, Congressman O'Rourke, thank you. Good morning. First, from my humble perspective as the president of MOA for the past 13 years, this committee's actions have been the driving force, I believe, in sustaining the all-volunteer force while the nation has been at war. Leaders make a difference. You all have made a real difference. Thank you. As for today's subject of military health care, MOA's first guiding principle is to do no harm. We think it's important to preserve what's working and fix what's not working. In the category of what's working, we would include combat casualty care, the overall quality of military health care once it's delivered, TRICARE for life, pharmacy programs including the mail-order pharmacy, and TRICARE standard for the most part. On the latter score, MOA's recent survey of more than 30,000 beneficiaries found standard participants had a higher satisfaction rate and significantly lower dissatisfaction than prime beneficiaries. In the list of things that are not working, MOA would include first and foremost the fundamental inefficiency of a system built around 3 separate military service programs with no single budget and oversight authority. We fight wars jointly, thanks to Congress's insistence in the 1980s over the objection of all the Joint Chiefs. Why can't we do the same in medical? In layman's terms, there are simply too many cooks in the kitchen. As a result of our survey, It confirms serious shortcomings in the TRICARE Prime appointing and referral system, the Guard and Reserve TRICARE coverage, as Scott alluded to, the patient load in military treatment facilities where military providers see far fewer patients per week than civilian providers, and inadequate case management of the higher cost or at-risk healthcare users. One of the biggest problems is a serious disconnect between rhetoric and reality on DoD healthcare costs. Every year, some defense officials offer dire budget projections of healthcare costs they say are spiraling out of control. But recent history shows these projections have been consistently wrong. Slide, please. I don't know if you're going to be able to put it up there. Okay. The chart displayed reflects the reality. DoD health costs have been flat or declining for the past 5 years. Figures through FY14 are actual expenditures. FY15 and 16 are projections in the latest DoD report and the FY16 budget. As you can see, TRICARE for Life costs have dropped significantly, and purchase care costs have been flat or declining. A prime source of cost increases has been in-house military care, which is mainly a factor of medical readiness and system inefficiency. In assessing what changes should be pursued, our statement for the record offers a number of guiding principles. 4 key ones include, first, means testing is inappropriate for military health benefits. Reducing benefits for longer and more successful service has very negative career retention effects. Second, readiness costs should not be passed on to beneficiaries. When military providers are deployed or military facilities are inefficient and more beneficiaries are pushed into the private care, that's a cost of doing military business, not a personnel benefit. Third, the military health benefit should be the gold standard, a top-tier program that's substantially better than those offered by the best civilian employers. And lastly, each similar group of eligibles should be provided similar coverage. We are not in favor of an FEHBP-style system that means those with more income can buy better coverage. Finally, our written statement offers 12 specific recommendations, but in the interest of my time and your time and the colleagues' time, I will not address those now. Mr. Chairman, in closing, I can assure the entire committee that MOA stands ready to assist you and your staff in any way that would be beneficial. We all want to get this right. Thank you.
Thank you, Mr. Chairman and Ranking Member Davis and other members of the subcommittee for inviting me to speak today on behalf of the National Military Family Association and the families we serve about what's working and what's not working with military health care for families. Our written statement submitted for the record contains a summary of what we hear most often from currently serving military families about their experiences, good and not so good, in accessing care and the quality of the care they receive. We appreciate the provisions that you included in the recent NDAA as a step in addressing some of those issues about access and quality. But it's been more than 20 years since TRICARE was created. It's time for a holistic examination of TRICARE in the military health system, not tweaks around the edges. But we remain committed to the concept that the reform discussion must start with how to build and deliver the best benefit possible for our military families, which I think I heard from you, Mr. Chairman, not on how much families should pay for that benefit. Military health care must meet the unique needs of military families, such as frequent moves and deployments, as well as address the concerns of families in remote locations, individuals with complex health care needs, wounded service members, and our National Guard and Reserve members and their families. Service members must get the care they need to be medically ready. Above all, coverage, access, quality, and cost should acknowledge the value of the service and sacrifice of troops and their families. As Admiral Ryan said, our military families deserve nothing less than the best possible health care coverage and care. We do know that many of our families remain satisfied with TRICARE, the care they receive, and the low cost of that care. Our concern for these families centers on what could happen to their care if financial pressures take a greater toll on military hospitals or the TRICARE benefit over time. When we ask for families' input about their healthcare experiences, they routinely cite difficulty in obtaining timely appointments, bureaucratic hassles to obtain referrals, lack of continuity of care, difficulties in navigating the system, especially when moving from one military community to another, a lack of coverage for certain services, and poor customer service. While most families rate poor access as their #1 healthcare quality issue, some do tell us of experiences of less than satisfactory care. Examples similar to what was found in the 2014 Military Health System Review conducted by the Department of Defense. But we do know there are models of timely access and quality improvements in pockets of the direct care system, but there doesn't seem to be a single entity with the power to drive implementation of those improvements across the system and hold those in need of improvement accountable. Based on what we hear from military families, here's what we'd like you to look at as you begin your review of TRICARE. Changes in an enforcement of access, quality, and customer service standards must apply across the entire military health system, direct care and what's purchased from the private sector. Before initiating additional recapture efforts to bring more beneficiaries into the military hospitals should be required to certify they are meeting appointment access standards for current patients. Reconsider the concept of a unified medical command to provide a single entity responsible for ensuring consistency and quality accountability across the system. Ask how private sector coverage options, patient engagement efforts, and quality standards can inform TRICARE reform. Consider the demographics of military families today in updating the TRICARE benefit and in managing the balance between meeting their readiness mission and delivering an employer-provided healthcare benefit to families. A Medicare-based reimbursement system and a focus on troop and provider readiness for war don't easily translate into a model of coverage and care for a population of young families with kids. Here's a statistic for you. Of the 1.1 million children of active duty service members, almost 50% are age 6 or younger. Questions about any proposed changes to TRICARE should also be asked about the current system. How does this structure promote military readiness? How does it ensure timely access and quality care at the best possible price for both beneficiaries and the government? In an era of budget constraints, when military families see any proposed change in their benefits as just another attempt to cut costs, it's important to rebuild their trust and to show them their service is valued. We hope this hearing is only the beginning of a thorough discussion of how to deliver the best care benefit to military families. Thank you.
Thank you. I appreciate all of your testimony. And since, Ms. Davis, you may have to leave soon, I will defer my time and give you the first 5 minutes.
Thank you very much. And again, thank you all for being here. Ms. Reeser, maybe I'll wanted to ask you to really just to follow up, I think, on some of the discussion, because one of the concerns that you've stated, and I think has been stated often, is about access standards. And what we know is that there isn't a whole lot of awareness sometimes of what those DoD standards are, which the awareness may be low, but the standards are high in a number of cases, and yet that's not something that I think is people are able to relate to within the service that they're getting. And so how would you do that? What are we missing? What's not happening to increase the standards so people really can, I think, demand in many ways that they get the care that actually has been developed for them?
You're absolutely right. There isn't a lot of awareness about the standards, and unfortunately, it's not just on the military family side. It's on, and this is mostly in the direct care system, where there aren't the same kind of accountabilities that are in the purchase care contracts. There's not a whole lot of awareness among the people who are charged with giving military families an appointment. So if a military family member, even if who knows about an access standard, calls for an appointment for a sick child and said, this is urgent care, the access standard is 24 hours, typically they're going to get the response, sorry, there are no appointments. Well, can you send me out for urgent care? Sorry, we're not doing that right now, which is why we're so grateful for the pilot. A military treatment facility's response to meeting access standards shouldn't be to tell a military family with a sick child, go to the emergency room and wait for 9 hours. And that's what's happening. So there's an awareness needed on the military hospital side across the culture and a commitment to meeting those access standards. We don't hear a lot from DoD about access standards lately. We really did a lot when TRICARE was first created. And that was the promise of TRICARE Prime. You give up some control over your care, and we'll guarantee low cost and access. The low cost is still there, but the access isn't.
Yeah. Any others? Do you have a sense, Admiral, about how do we
I
do
couldn't
that
agree
better?
more. What our survey of over 30,000 folks says is that the real issue is with TRICARE Prime, the greatest dissatisfaction with meeting the appointment timelines or getting specialty appointments. And it's double the dissatisfaction rate in TRICARE Prime, and specifically in the military treatment facilities is where rather than the purchase care part of TRICARE Prime. So it's 15 to 19% dissatisfaction with the appointment, getting the timely appointment or getting a specialty appointment. It's half of that in TRICARE Standard and even less in TRICARE for Life. And so the figures show it, exactly what Ms. Razor was talking about.
Yeah, because there are some reports that would indicate that the MTSs are actually meeting the standard, but
Well,
that's
we've
so
had discussions with
why
DOD,
this
yeah,
disconnect?
yeah.
We've had numerous discussions with the department on how do they measure access. If I call and ask for an appointment for a sick child and I'm told, call back tomorrow or go to the emergency room, how does that get recorded in the system? How does that response, call back tomorrow, get recorded in the system as meeting or not meeting access standards? And what we were hearing from the department is they weren't really sure. And that was one of the things that came out in the military health system review, is that there were a lot of questions about how the military was measuring access.
One of the principal problems, and I know that the healthcare providers in MTFs are really professional, consummate professionals and want to do a good job, but when you look at the number of appointments that they have in a day versus what you have in the purchase care, it's not even close to what is in the purchase care. Now, that may not be the fault of any of the healthcare providers. Dr. Heck has been in the system. That may be the administrative requirements that are placed on them. It may be the lack of administrative support, so they end up doing clerical stuff as well. But that is an area, if we could fix one thing, it would break a lot of this dissatisfaction, I think.
Well, okay, thank you. Yeah, thank you. Mr. Bissom, did you want to comment on that?
I was just going to interject quickly. I'm running out of a little time here. When guardsmen go on to TRICARE Prime and they are called to active duty and there's a switch in this continuity of care, our members are now deployed and their family members are left to work this convoluted nightmare with them, now thinking of their family, and it affects readiness. So.
Okay, thank you. Thank you very much. Thank you, Mr. Chairman.
Thanks. So, one of the approaches that we're trying to look at from the subcommittee perspective as we tackle this is, from the 30,000-foot view, what is the primary purpose of the military healthcare system? What's the primary reason that we have a military healthcare system? And then from there, try to bring it all the way down to the tactical, how do we provide that care? So I would ask each one of you, on behalf of your association, to your association, what is the primary purpose of the military healthcare system? Mr. Poston?
Well, I would say that in our case, it's not this way, but it should be this way, that a guardsman should have the same health care regardless of their duty status, that it should be something that fits the needs of the service member and their family, and that it's something that they have 365 days a year until they maybe opt to change that. And it shouldn't change at any point regardless of what happens during that year.
Admiral?
Well, I think you said it in, both of you and Madam Ranking Member said it in your open statements. It's readiness. But we think an important part of readiness is making sure that you can also take care of the family. And so the way you phrased it is the right way. And that's why when the commission came out with this FEHBP proposal, we could not see how the military MTFs could sustain their readiness with that proposal. And that's why we would rather, you can't evolve this system. It has to be reformed, and it can't be piecemeal. But it's got to start with the readiness and making sure that all of those MTFs have people that are qualified to do what you've done, to deploy and take care of our troops. But an important segment of that readiness, as Scott pointed out, is when somebody goes over the horizon, they want to know that their family is being taken care of and seen. Thank you.
All right, Ms. Razor.
I agree with Adam Ryan. It is readiness first. The system has to ensure that service members are medically ready to deploy, that they and that they have the best possible care when they are deployed. We don't want to mess with the successes that we've seen in combat and care. But that's prime importance to families as well. They want to know that their service member is well taken care of when put in harm's way. But the Department of Defense also has an obligation to provide a high-quality employer-sponsored benefit. And where we're seeing, so it's a dual purpose, and what we're seeing is the conflict between those two goals in the military health system. Too much emphasis on readiness leaves families without appointments, and pressure on readiness dollars leaves families and sometimes service members without care. So I think the challenge for you as you do this work is saying, how do we get rid of that conflict between those two missions of the military health system?
Great, thank you. I'll save my second question for the next round since it's going to take longer than a minute and a half. Mr. O'Rourke?
Thank you, Mr. Chairman. I'm more familiar with the VA healthcare system. I've been on the VA committee for 3 years and on this committee for almost a year than I am the TRICARE and DoD system. But you mentioned something that caught my attention because we've heard it so often on the VA side, which is access standards and accuracy in measuring access standards. In the VA, it was wait times. And, we were told with all certainty by the VA 2 years ago that we were seeing everybody within 14 days. And there was the infamous wait time scandal in Phoenix. So I would love for you to expand on that a little bit and tell me what your members are seeing or what the concerns are or what your recommendations are for assuring that we are meeting the standards and that we're measuring those accurately. In our case in El Paso, we bypassed the VA and just asked veterans directly and did a survey of veterans in El Paso to find out what their real wait times were. And instead of 14 days, we found for primary care, it was 81 days on average. For mental health care, 74 days. So that, and then the second question for you, and then anyone else who'd like to address it, one of the MICR-MIC's recommendations was having greater interoperability between VA and DoD. And there's this DoD-VA Joint Executive Committee to standardize and enforce collaboration. So any thoughts on that would be appreciated. And I'll start with you, Ms. Razor.
Okay, I'll start with the access question. We haven't heard of families having the same length of wait as what some of the worst stories that came out of the VA are. But that said, we are hearing from families who not only are being told they have to wait for care, where there is no mention of an access standard, but there's also what I term as silly rules. Processes and procedures at military hospitals and clinics that vary, but that put barriers up between a patient and the provider in accessing care from that provider. Rules about when you're transitioning on a military move from one installation to another. What do the enrollment process from TRICARE contractor to TRICARE contractor is pretty seamless. Where our families are having problems is getting that first appointment with a primary care manager in a military hospital, or if you've come in with an existing health condition. One of the examples we referenced in our written statement was a spouse late in her pregnancy who moved from one military community to another, and even though she was obviously pregnant, had her records with her showing she was high risk, was told she had to take a pregnancy test before she could get an appointment with an OB. So she came at 28 weeks, didn't see the doctor until 36 weeks. That's just wrong. And we've heard that from other military families, that the process they have to go through when they move creates a barrier between them and care that doesn't show up readily on access standards. Just a minute on your issue about interoperability between DoD and the VA. Our families who are going through transitions say the process has to be seamless, especially if you have a wounded service member. There's still too many managed processes for that individual, too many different case managers, too many barriers. You're fixing some with the drug formulary, for example, but there's still some other ways that could be made better. So we agreed with the commission on that.
Too many different systems.
Yeah.
Admiral Ryan?
Well, I go back to the president's first term. He cared enough about this that he called about 6 of us into a room, major VSOs, and said, this is important that we get this joint DoD-VA medical record, and I want it to be a medical record. He called the Secretary of Defense and the Secretary of VA out of separate meetings to be there, to look everybody in the eye and said, we need to get this done. Unfortunately, it's been well documented that leader after leader on both sides have not been able to overcome the intransigence of the bureaucrats over there. You all have wasted a lot of money on this, and the latest is now they're publicizing that you can look at the other person's record, but it's really an embarrassment. And I see well-intentioned people at the top say we're going to be involved in this, but they get overtaken by events, and I think they leave it to other folks, and they don't have the clout to get it done.
Yeah. Unfortunately, I'm out of time, but I'd love to get your thoughts either offline or on the record. And with that, I'll yield back to the chair. Thank you.
Thank you, Mr. Chair. Thank you for being here. We've had a lot of hearings now on this subject. We have met with the commission, active and retired members of the services and the DoD, the Surgeons General, the private sector, the public sector, and now stakeholder groups. And I'm reminded that the purpose of walking is to get somewhere, and we're getting to that point where I think we need to come to some kind of a landing, and that's what we're working on. And as I think about our objectives, it's clearly readiness, and it's clearly keeping our end of the bargain, family care and providing for people. And I think those two are front and center to me. Rather than asking you detailed questions, I'd actually like to lay out a broad framework that's beginning to gel in my mind, and I'd like you to react to it. And that framework is a couple of changes to the current system. One would be a consolidation of the medical health system into a consolidated command, rather than having each service run their own hospitals. And then the Surgeons General would focus on training, equipping, and supporting, not running a system. Two would be granting broad authority to this central command to change plans, to change delivery, within broad cost constraints that we would define here. Three would be investing in centers, military centers in areas of concentration of troops and families, and increasing in other areas where there's less concentration, increasing access to private health care. And then lastly would be ensuring a vibrant military health reserve system so that we can make use of healthcare professionals in the private sector who agree to be on reserve status and go wherever, whenever. Could you each take, I've only got 3 minutes left, could you each take a few moments to talk about pros and cons to that framework?
Scott, you didn't get a chance to talk, so. Yeah.
So actually, a part of my written testimony, my organization would actually support the basically FEHBP plan and bringing everything over to OPM. That they manage it for federal employees, and that there could be a structure in place that they could support that for service members. In terms of access, better access to private care, we would, from a readiness perspective, we would have to ensure that doctors understand readiness levels for the different services. There's different standards for every service member, and so in order to do that, that's asking more, putting the onus on them. So if a service member comes in perhaps with the flu, but they look to be overweight, that a doctor would say, okay, I'm taking care of your flu symptoms, but I also am now responsible for reporting this. One thing, and this is, as you're looking at reform, this is somewhat outside the box, but in order to go that route, perhaps a cost offset for that doctor would be that the federal government reimburse some portion of their federal student loans.
I'm going to stop you there because I want the other
Okay.
two. I would invite written responses to this as well.
Okay. Wow.
But let me hear from the other two of
Well,
you
thank
briefly.
Thank you, Congressman. We would definitely like to explore this with you and the committee. Actually, as you know, you were very supportive of a unified command and a single budgeting authority. We think that makes eminent sense. Consolidation, I think, would have to be under DOD. We would get nervous if it went, our association, if it went to OPM. I'm sure they're fine people. They do a good job for civil servants. But as Joyce said, we think DOD has the responsibility there. Access is going to be a problem for everybody. We see it in the private sector now, too. It's a big deal. We think getting the military treatment facilities more efficient would really help with the access, and then having a much more collaborative relationship between the MTFs, the managed care, and the purchase care. It's almost non-existent now. It's at arm's length. We waste a lot.
Yeah, I agree. I think I would make one point. I would love to talk to you more about this idea of investing more capacity in military centers where large populations are and doing that better coordination in other areas. I think military hospitals.
Here, Mike.
Oh, sorry. I think military hospitals should be staffed not just based on readiness needs, but what the community capacity is or isn't. So if you're sending a lot of military families with their service member to a remote location, then maybe the military does have to put in a few more family practice docs and pediatricians than they would other places. And so it's not just on, we'll let the private sector do what the military can't, but how does the private sector work with the military facility in that location to build that capacity in the community?
I thank you. I yield back, Mr. Chairman.
Thanks. So I was going to, my follow-on question was going to be, how we kind of look at the 3 ups and 3 downs of the system. What are the 3 things you think they're doing well? What are the 3 things, if you could wave a wand, you would want to improve? Actually, Admiral Norbert, I think you did that actually in your opening statement, and if I had them right, you kind of said the ups were combat casualty care, TRICARE for life, pharmacy benefits, TRICARE standard, and the quality of care.
Yes, sir.
And the 3 downs were inefficiencies of 3 separate programs, TRICARE Prime and TRICARE Reserve Select.
Yes.
Do you have anything else that you would add to
I would
either of
just
those two
say,
columns?
in relation to Scott, what he said, that we think one of the recommendations we have in there is if you want to actually look at an FEHB type of program, doing it with the Guard and Reserve might not be a bad idea, because right now it is so lack of continuity, disjointed. They don't get equal treatment, so that's one of our thoughts.
Okay. So, Ms. Razor, what would be your 3 ups and 3 downs?
I think my 3 ups would start with the combat care. This has been a success story. I think the military families say they want to go to a military hospital because they believe the providers understand their life. So that cultural competency. And I think for military families, for currently serving military families, the cost of the care it's important for our very young military families to have that low predictable cost. I think the three downs, it's access, inconsistency, and access. If you can't get an appointment, everything else is a problem.
Great. And Mr. Bosom?
Yeah, I honestly, for the most part, I echo that sentiment. I have an example from the previous line of questioning. I have a member filled out our survey. There was room for additional comments. They had torn ACL, took 5 months, ended up having to do it at at an outside hospital, a civilian hospital. In fact, a doctor, this was someone in the National Capital Region, obviously, because a doctor at Fort Belvoir actually said, with your age being 64 years old, you should just wait till closer to 70 and have your knee replaced. I mean, that's not something that's said.
And then, in one of the previous panels, we had the former Surgeons General, one of which was Admiral Cowan. And, he talked about, obviously, his longitudinal perspective that he's had for being involved for so long, that, when TRICARE was originally envisioned, the idea was that all of the health care actually would be provided in MTFs until the military staffing of that MTF had to deploy, and then the care would go to, out into the community until those returning physicians, nurses, medics were coming back to the MTF. And he had this idea, or his thought was that we should try harder within DOD to recapture more of the care that we've let go outside the gate via TRICARE back into the MTFs. Now, I understand the point that you brought up, Ms. Razor, that, hey, if there's no appointments to take care of the current beneficiaries, how are they going to provide appointments for those outside the gate? But assuming that could be fixed, and that's a big assumption, but let's say, assuming that could be fixed, what degree of reticence do you believe there would be amongst your beneficiaries, your members, of wanting to come back into the gate? I mean, would they need to be incentivized to come back in if they've been getting care outside the gate? Or how do you think we would be able to accomplish that, to get them to understand or want to come back into the MTF? Ms. Razor?
Well, I think it's important to remember that most of our active duty families are already in the MTF to varying degrees. Air Force has downsized a lot of facilities to clinics, so there's a lot more care out in the purchase side for Air Force families in many locations. I think our active duty families look to the military for care. They believe this is something they've earned. This is something, as I said, these are providers who supposedly understand their life, but you have to convince them. We've also heard from a lot of military families that they're making the switch to standard because they want more control, they want more access, and so the military hospitals are going to have to convince them that they offer the care that they need. That includes things like after-hours care. That includes other options than waiting with a sick child in the emergency room. That includes getting rid of some of these silly rules. So I think our military families can be convinced, but it's up to the military hospitals to show they understand what families need.
When you talk about cultural competency and the providers understanding the life of the duty member, do your members talk about hospitals or military healthcare facilities that are primarily staffed with civilian contractors nowadays versus actually active duty healthcare professionals?
They actually like the places that have more civilian providers because generally hours are better and it's easier to get an appointment.
I think we're rolling up the stream. It's going to be very difficult. Our survey of over 30,000 indicates that with TRICARE for Life, which retirees are very important, 84% say it's not very important to go to a military hospital. Standard, 90% say not very important. And then Prime, 61% not very important, including currently serving. As Joyce said, they're most interested in access and choice. So it's not something that is working well right now, and it's not going in the right direction. Admiral Cowan's a great American, but you know, Dr. Heck, even in your area, that purchase care provides 58% of the care on the West, and only 42% is done in the MTF. So it's a big hurdle.
Mr. O'Rourke, another question?
Thank you, Mr. Chairman. Admiral Ryan, I just want to tell you that your comments are spot on in terms of the need to force interoperability between DOD and VA. And it's really encouraging, actually, the anecdote that you told us of the President calling in the two secretaries responsible, and yet deeply disheartening that as we enter the final year of his term, nothing's happened. And he really is the only person who can referee this dispute. But I'd love to join my colleagues on this committee to do everything we can from a legislative perspective to try to force this. However, as you probably know, that there has been legislation requiring this, mandating it, that the administration, for lack of a better word, has just refused to implement. And there's no excuse for it, and it is, in your words, very embarrassing. And the consequence is that you have wasted taxpayer resources, and you're not maximizing the health systems, the two largest health systems in this country. And just one last anecdote, we had a hearing on this with the Government Oversight Committee a couple months back, and the excuse from DOD's perspective for not doing this is that their systems need to work on a submarine, which, to me makes no sense. We can have it work on a submarine, we can have it work in a VA clinic. But Mr. Bosom, you didn't get a chance to answer that question on access and interoperability between DOD and VA, and where you see some opportunities. So I'd love to give you a chance to respond.
The point I was going to make was actually about that ACL surgery, so I was able to work into another answer. As far as interoperability goes, and the comment was made that I think that there are decisions being made at high levels that don't actually make it down to the people who end up, at the base level. So that's a particular problem that we're seeing. I would say that as far as it's unfortunate that there are numerous members of the Guard and their families that aren't allowed to use the MTF, and so I think that should be across the board access, and I think that our members would welcome that because it's a one-stop shop. They're around other service members. They would be more willing to go, and they feel more comfortable, and they would like their primary care provider, and so. Yeah.
Let me ask Ms. Razor a question. This is slightly dangerous because it's based on anecdote. But my sister is an ER nurse in El Paso, and we have William Beaumont Army Medical Center, which is an excellent Army medical center, and they're just completing a $1 billion new William Beaumont Army Medical Center 9 miles east. And she said it really struck her the number of military families who showed up at the ER to get primary care for non-emergencies that I assume TRICARE is paying for, despite there being a world-class Army medical facility on base. Any thoughts on that in terms of reforms that could address that? If true, doesn't seem like perhaps the best use of resources, and love to get your thoughts.
Well, I think it's when one new hospital that I'm not going to mention opened, military families who went there said, beautiful new building, same old military customer service.
So it's the access issue.
So it becomes an access issue. So the question for me is, how late are Beaumont's primary care clinics, pediatric clinics open? Do they have after hours? What's the provider workload? Do they have, how are they augmenting military staff with civilian staff to help promote access? But if she's seeing military families for primary care in a civilian ER, those families are probably there because they didn't feel they had any other options.
That makes sense. That makes great and great questions for me to ask of William Beaumont in terms of their hours and availability. Thank you, Mr. Chairman.
Admiral, I had a follow-up question for you. You mentioned that you thought consolidation should be under the DOD, not OPM. I agree with that, but I'm wondering briefly what your reasons for that are.
Well, because first of all, with the all-volunteer force, the people that should have ownership of retention should be DOD. And so we start out, we're an officer association, but we start out concerned most about what about the E5, 10 years of service, combat experience, sitting around the table, family of 4, what do they think of this or that? And I just think that that member, when they go over the horizon, he or she, they want to know that somebody's got their back, and that has got to be DOD with the all-volunteer force. OPM does a great job with civil service, but DOD ought to be responding to DOD.
Okay, thank you. Yeah, and I think there are meaningful cultural changes between the two population groups.
Yeah. One of the things that we found, and it's in regard to the chairman's question too, about what should we do in the MTFs. We did a study with United Healthcare called Ready to Serve, and that was done by RAND, and it shows that the families really do have concerns about, do the people understand us? But guess what? The practitioners have even more concern, particularly in the mental health area, that they don't feel that they're qualified to help somebody coming from a military situation if they come in for a mental health issue. So a lot of people are trying to work on that. Some states are doing a better job. But it's not only the concern of the family, but the providers themselves, this split between the 1% and the 99%. They want to do the right thing, but they're worried that they don't know what that right thing is if that patient comes to see them as a civilian.
Yes. My other question was for Ms. Razor and then Mr. Bosom. The Admiral, mentioned that you polled very high, your members polled very high on access and choice being the highest priorities. I think that was you that said that. And it seems to me as I'm listening that training of physicians and other healthcare professionals is vital on the readiness side of the objective, and access and choice is vital on the family care side. And how do we balance those two? I wondered if your members would, if you have polled them, do you think they would poll as high, or maybe you've already done that work and you can answer, would they be in the 80 percentile as well, that access and choice are the highest priorities?
I think for currently serving, and we are in the process of polling, we also sent families to MOA's survey to fill that out, and we're in the process of polling a larger sample of military spouses. What we hear from military spouses is access. If they can't get access, then choice becomes important. And that's why we are hearing of families who are making the choice to assume more out-of-pocket costs for their health care so that they have more options under TRICARE standard.
I thank you. And Mr. Bosom?
So I'm flipping through here. Our poll shows that does TRICARE Reserve provide health care in a quick and timely manner? All the time is 46%, and very little of the time is about 5%. And then let's see, does TRICARE provide a good selection of network providers to meet medical needs? This one's really across the board. It just depends on when it works as advertised, which some of our members say TRICARE works and it's great when I get it, but otherwise no. So I'm happy, and it should be in front of you on, let's see, it's about the fourth question.
Okay. Since I have a moment, Admiral, I'd like to say that your representatives in southern New Jersey, which is what I represent, have done a superb job of making me aware of the issues that matter to your members. Whether it's concurrent receipts or other things, they've really been very, very effective at being in front of me on those. And Mr. Chairman, I yield back with that.
Well, I'm going to keep going because we've got you here, and I want to totally exploit the opportunity to get your perspective. So, again, as we've been working through this, and this has been a very iterative process. Each time we get another panel before us, we pick up another pearl, or at least I pick up another pearl that sometimes changes the entire calculus that I had before that committee hearing. I was impressed that each of you said that, the primary goal is to maintain combat casualty care, right, as the primary goal of the military healthcare system, and I would certainly agree with that, certainly when we look at the advances we've made over the last 14, 15 years. So I'm throwing out, I probably shouldn't do this on the record, but I'm throwing out a concept, okay? So I don't want this, this shouldn't be publicized in any newspaper article that this is my idea, but a concept. I know, too late, otherwise my phones are going to start lighting up already. So with the idea of trying to maintain combat casualty care, right, which basically comes into the idea you need a healthcare provider force that's ready to be able to provide that care, and you need a medically ready force to be able to deploy. It would seem that and that comes at a cost. Readiness comes at a cost, and I think that's one of the things that DoD fails to recognize. Well, they recognize it when they write the check, but they don't realize that if you want to be ready, you've got to spend money to do it. And I use the analogy of like a civilian trauma center. Civilian trauma centers know that they're going to lose money. It's because you've got to have all those resources ready to go at the flip of a switch 24/7, whether you're using them or not, and that comes at a cost. So if we want to say that the primary goal is to have that medically ready force, medically trained and ready providers, and maintain combat casualty care, that perhaps, as Mr. MacArthur said, we focus providing that at military medical centers of excellence. that would be the full inpatient capability MTF, and those would be located in areas of high troop concentration, right? If we downscale other facilities then to, let's say, outpatient clinics with no inpatient capability, and we want to, well, I should go back. To do that, we need to recapture all the care in those areas into those facilities so that those medical health care providers can get the training that they need. Not just on combat casualty care, but, you know, we do humanitarian missions. It's delivering babies, taking care of pediatric patients, taking care of, you know, asthmatics and everything, heart failure and heart attacks. If I'm hearing correctly, in order to do that, we've got to increase access, which is the hours of operations, the number of appointment slots, and the staffing and the specialists available within the MTF. Outside of those areas of concentration, then, perhaps more of the care is provided through military outpatient clinics. So on a post, base, or camp, it would be an outpatient clinic with no inpatient capability, and inpatient services would be provided on the economy. And then to address the Guard and Reserve issue, that perhaps, so that there's not an issue with changing in duty status, that they're allowed to enroll in FEHB or an FEHB type equivalent. I mean, honestly, I mean, previously, actually right now, the law says that if you're eligible for FEHB, you're not allowed to enroll in TRICARE Reserve Select. So perhaps, you know, as a broad framework, and again, I know there's a lot of holes in that, but give me your first, you know, response to a system that would look potentially like that. Ms. Racer?
I think there's some merit in it. I would have just a couple questions. My first would be, even if you concentrated a lot of that readiness care in a few locations, would our population still be big enough on its own to allow military medical providers to get the skills they need to remain combat ready? And there's a lot of discussion about, and there's a model in San Antonio where the military facility is a level 1 trauma center, helping, you know, supporting the community as well as the military. So I think that's one question that would have to be considered. The other would be, as I said earlier, in designing where those smaller facilities, what's the interaction between the military system and the civilian provider network? Would there be enough civilian capability in the provider and the specialties that our families would need to meet the demand from the military folks? So I think that would be my caution in designing that, is making sure that capacities and access is still there in those smaller facilities. And then the other is the bigger question. I mean, what will it take to keep our providers ready and trained?
Okay. Admiral?
It's a very interesting concept, and we would like to talk to your staff about it some more. One big thought, you know, the VA has their polytrauma centers at the different geographical areas, and so there's kind of a lesson that could be learned maybe about that. Do they get enough inflow for the spinal cord and brain injuries and all to stay current while they're doing everything else and pulling in the regular patients, as you said, not the babies necessarily, unless it's one like Chicago where they do both. But so you've got a little bit of something here you could get some experience from. I think, no question, right now, the military does an awful impressive job. I'd say they're leading the country in this type of casualty competency. So that part of it is working well right now. I wonder, going forward, if we could really get the trust of the people to come in to the thing when you're going to then just deploy them when something happens. And so it would have to be, it couldn't be with the 3 surgeon generals the way it is now. You would have to have a unified command where it's in the plan that we're going to have a much more collaborative. For example, these 6 areas of concentration right now, they're committees. Nobody has the authority to move the dollars around. Nobody's really in charge. They try and work together. But you got to have somebody in charge, and somebody can move dollars around. And then you've got to embrace the community, the purchase care, and have, you know, a system where it's visible. The appointment system is visible to everybody that is trying to meet that need. I think it's doable. You almost have it right now. But what you don't have is the unity of command to make those systems, the incentive for those military systems to be as efficient as to purchase care.
Great, thank you. Mr. Wilson?
Well, we know that this is a multiple-year effort, and we know that, you and your staff are going out in the field and meeting with service members, reserve component, active component. What I can say, I don't really want to speculate. What I'd say is I will just, continue to work with your staff and to, get a better idea of this concept and perhaps tailor the survey we're already sending to our members in a way that could better get results for you.
Great.
Mr. Chairman, I would just say, based on that, our recommendation that 15 other associations and military coalition have supported is try it in one of the major 6 areas and give DHA the authority to actually move the dollars and control it, and do the same thing with the Guard and Reserve. Try that, and if it works, then wow.
Okay. And that is perfect timing on that note, as the bell has just rung. And since I'm the last man standing, so I want to, again, thank you all for taking the time to be here and to offer your insights and opinions. They're very valued, and we certainly will take them into deep consideration as we move forward, and I'm sure you'll be back as we start moving forward with actual proposals. So again, thank you, and the hearing is adjourned.